Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only.
Bienvenidos, everybody. This is another episode of the Life of Flow podcast, your favorite, most listened, and top of every chart podcast in the world. Today, we're putting out another show from the Link series. Link is Leipzig Interventional Course. We are recording in Leipzig, Germany, with some terrible weather outside, but some amazing warm conversations in the studio. And today, we had the true pleasure of having a good friend and a person we both look up to, Sahil Parikh. Sahil is an interventional cardiologist at Columbia, and he carved a little time to share a little bit about his journey into the vascular world, and then some pretty spicy topics on, I'd say, controversies in vascular care, and then discussing a little bit about where, the interventional cardiology as a specialty is moving into, and maybe potentially some things that he believes need to happen to further improve care across America.
And Miguel obviously hated whenever I went off on tangents as usual, so that was great too.
He really tried to take us off the course today, off the beaten path, but I was able to rein that bull back into the conversation, and hopefully you guys don't get as bored as I did when he started going off the reservation. Anyway, stick around. It was a great show. So bye-bye. All right, we're here with the Link series. This is another Life of Flow episode for all of the billion plus followers that we have at this point.
A billion.
AKA my dad and Lucas's mom.
Maybe my sister once in a while.
Listen, so I'll go home, my wife Jenna, and I'm like, babe, you got to listen to this last one, baby. It's a great show. She's like, I have to listen to your ass talk all day. I don't care listening to you more. She doesn't want to hear a single.
You know how I know that you're getting old? Because you keep repeating the same stories over and over.
He didn't know
but
that.
The people that, anybody that listens, like my mom that listens to this, knows
have you ever
the story
heard
3 times.
the Joe Rogan or the All In Pod? That the stories over and over because he tells them to other guests.
Yeah.
So
I'm just saying you're getting old.
You pick on me with cheese sticks.
Yeah.
Every day as if it was like a funny joke. It's not even funny anymore.
Did somebody mentions cheese sticks to you
today?
Yes. Yeah, because it was funny.
Well, and so to my point, I can say my stories over and over. I'm not getting old. I just know that they're on cue. Anyway, back to the most important part of the show. We have beers.
Thank God.
Thank God it's
that
after.
time of day.
Cheers. Salud.
Salud.
It's after
Salud.
3. They told me that we were allowed to drink on site. So,
It is Germany.
Sahil, thanks for being here, man. Again, I appreciate you. We certainly go way back. Part of this meeting, this convolvulated family on the road, if you may, that when you go to these meetings, you hook up with, you connect, big fat smiles and hugs, and we give each other support for all the issues we're going through. And so you've been just one of those, studs, a fun guy to be around, a very, very natural, very authentic person. And then you always come with just phenomenal data. It's like every year you have something new to share, something exciting to share. And so it's been great to be your friend, and certainly an admiration to be your colleague.
I appreciate it. Well, and likewise, you guys are changing how we take care of people, and that's what this is all about. I agree with you. It's funny. We have this sort of second family that my wife is jealous of, because she thinks that every one of these meetings is a nonstop party. I told her only Thursday night at Link is a nonstop party.
We try to just keep it to one night. Yeah,
exactly. Right.
Yeah.
So, I think until then, it's all business. But it's great to be here. Thanks for having me.
No, thanks for coming.
I think most people know about you and will resonate within the vascular community on what you've brought to the table from a science standpoint. But a lot of us, and I include myself there, don't necessarily know the personal side of you. And always as a first guest, because we certainly look forward to having you more times, but as a first guest, we love to understand a very basic thing, which is, how did you end up in this? And we were talking a little bit offline on how potentially unsexy it is to just take care of stinky feet that are rotten. We love it. We're enthusiastic about it. But a lot of people say, what in the world is this poor man doing? Why did he could have been a real cardiologist and not just do this.
No doubt.
What kind of swayed you in that direction?
Yeah, no, it's interesting. So I was born and raised in New Jersey. Plenty of stinky feet there. Lots of vascular disease. But most importantly, I was always interested in sort of bioengineering kind of stuff. I broke a lot of bones getting into scraps as a kid, and I thought I was going to be an orthopedic surgeon. So I was very interested in biomechanics. And my older brother is 9 years older than me. So when I was starting in college, I went to Harvard. He was the good son. He took all the scholarships I turned down and went to, Rutgers and New Jersey Medical School for free. And he was an intern at Cornell in medicine and was going to do cardiology. And he came to interview in Boston at, all these prestigious training programs. And he stayed on the futon in my dorm room and went to his interviews. And he came back. He says, I don't know, I'm not smart enough to be here in Boston with all these guys. But I met this really cool guy who's doing research on stents. This is 1992, 91, 92. And I was a Harvard freshman. I said, so what does that mean? And he said, well, you should maybe look him up and work with him to do research. And I was still thinking orthopedics was kind of what I was going to do eventually. And I was doing, the usual thing as a freshman, just trying to survive. And then my intro to bioengineering class was my sophomore fall. And that class is a course called physiological modeling. And the professor was a guy named Tom McMahon, who basically, he's the guy who actually invented the track that set all the records for road racing indoors. And it was because he had tuned the track so that the return of energy maximized your speed. This is some of the things you could do with a bioengineering background.
That's incredible.
And so he was incredibly inspiring mentor, and his class was all biological cardiovascular systems models. It was, the heart is a pump and the arteries are pipes, and you learn about resistances as fluid mechanics principles. And I really enjoyed the class. I thought it was super cool. And I got really into it. I was doing well in the class, and he said, you really like this. You should do research. That's what we do here. That's the difference of being in an environment where people give a shit about you as a student and as a trainee. And I said, well, I've heard about this guy. And the guy's name is Elazar Edelman, who is a bioengineer at MIT and Harvard Medical School, a brilliant guy who at the time was a junior faculty, but had basically been the godfather of vascular drug delivery. His PhD thesis was in the delivery of heparinoids through perivascular drug delivery systems and modeling how that transmits through the artery, which turns out is an important concept in cardiovascular medicine today. So he was like the godfather of that. So
Awesome.
I emailed him back in a time when nobody had email, and he emailed me back in like 5 minutes and said, why don't you come over to the lab and, we'd love to have you come work with us if you're interested. So I remember I went to the stacks in the library. Our fellows don't even understand this because you had to actually pull all the journals and photocopy all the articles. Remember those days?
Yeah, of course.
And I read every one of his papers. I put on a tie like this, and I went to his office, and it was at MIT in an old army barracks where they invented radar, and the building was falling apart. And he was in a pair of shorts and a t-shirt, and there's all these crazy mad scientists running around. And I was like, this is pretty cool. And he's like, you know what a stent is, right? And I said, yeah, I've heard about it from my brother. And he's like, well, we're developing new stents that injure the blood vessel less and therefore cause less restenosis. And I was like, that sounds cool. And so he's like, well, I have this fellow, you know what a fellow is because your brother's a fellow. And he's like, he's working on this in animal models. So I met him. His name is Campbell Rogers, who at the time had just finished his chief residency at the Brigham and was a fellow in cardiology at the Brigham. So I was like, okay. So then, a couple of weeks later, I'm in an animal lab and I deployed my first stent inside an iliac artery, ironically, of a rabbit. And the rest is history. I'm still putting in stents in iliac arteries over 30 years later because I was hooked. And the whole thing was they developed the backbone of what is now the Zion stent. They called it the corrugated ring stent. was less injurious than the previous, Palmage stent, which was basically a slotted tube. And, all of the first principles, the engineering, interfacing with the biology is what got me excited about science and
So already,
bioengineering.
already before even going into
I was
training,
19.
you knew that
Yeah.
you wanted to do peripheral?
Well, I knew that I wanted to do cardiovascular medicine and interventional cardiology.
Okay.
And I thought for sure that my future was going to be doing basic translational science using bioengineering principles to develop new devices.
Did the thought ever cross your mind to do surgery?
I did, but I wanted to be intelligent. No, I mean, I think that I thought that the opportunity to be a physician scientist was much greater in a medical career than in a surgical career.
Which I think is probably
And I
very
think, as it
assertive.
turns out, my career is as a proceduralist, and as we all are now, we're much more valuable to our health systems as proceduralists. So you have to buy back your time to do science and teaching, the things I love the most. Which means that, you're basically in indentured servitude. But I thought that as a scientific career, it would be better to be in medicine than in surgery. So I think about it for sure. I thought a lot of people wondered, well, first I thought I was going to be an orthopedic surgeon. Then I realized that I was, more intellectual than that. And then I thought about cardiac and vascular surgery, but, at the time, the endovascular innovations were really coming out of cardiology. That may still be true. And the science that Elazar was doing was unique. So, I mean, he was a cardiologist, Campbell was a cardiologist, my brother's a cardiologist. It was a done deal.
Yeah.
There's no way they were going to let me, there was no way they were going to let me be a surgeon.
Yeah. And I would say even now, I would say just now we're starting to see more about this surgeon scientist, which I find it funny that they even need to almost turn themselves that. Like they have to give themselves that name in order to fight the system in which they need to coexist. And this is firsthand, where I know of colleagues of mine within the hospital system that have protected time, but they actually get some heat from it from other people because, like, why are you a surgeon and trying to be a scientist? That doesn't make any sense. To us maybe it does make sense, and certainly to that person it makes a lot of sense to have that protected time, but it's almost viewed with some degree of animosity by others. So you're not pulling your weight, or you're not doing enough for the department because you're not out there doing the cases. Well, somebody needs to progress, somebody needs to push. And so I can see this, certainly when you started, where the thought of doing surgery was absolutely consuming. Like there was absolutely no way that in the algorithm of the surgeon, a few years ago, that would even make sense. If still today, 2025, they're getting grief from some of their colleagues when they ask for protected research time.
Yeah. And that happens with, Demetrius. I have a colleague called Demetrius Miseralis. He does a lot of research in robotics and in like image analysis and stuff like that. And he has a day, Fridays, but I feel like he still feels the pressure to do as many cases or as many RVUs as every one of us.
We're all in the same boat, right? All of us that are academic physician scientists. And I would say that the culture of medicine is much more forgiving for this phenotype of person. And, there's the basic scientist, and then there's the translational clinical scientist. And, in cardiology, we have lots of examples. Eugene Braunwald, for example, the godfather of cardiology, was a translational scientist. He ran a laboratory for physiology research at the NIH. And that's, with the whole Brockenbrough-Braunwald-Morrow sign, it was something he figured out. He sent a patient to the operating room for what he thought was aortic stenosis. And the surgeon opened the aorta and looked at the valve. There was nothing wrong with the valve. So he took him straight to the cath lab from the operating room. They put a catheter in the ventricle and they showed that there was LVOT obstruction, but it turned out it was muscular obstruction. And the whole field of hypertrophic cardiomyopathy was basically born from that clinical observation. And the only people that can do those kinds of observations, certainly back then, were people who both took care of patients and did science.
Yeah.
And I think a lot of those types of innovations in the future are going to only be made by people who have the skills in both. I mean, nobody expects you to be the best in both domains, although everybody tries.
Right.
Yeah.
But I think you don't want to be the guy who says, God, I hope he's a good scientist because he sucks as a clinician.
Yeah.
Right? You need to have competence in both areas, and you need to be in an environment that supports that. And actually, that was one of the other things about Boston as a training ground. It was supportive of that sort of phenotype.
Yeah.
And, I remember, so fast forwarding, I went to Hopkins for med school. I wasn't smart enough to stay in the Harvard Medical School program.
I think you did okay.
Probably the best thing that ever happened to me was to go someplace else and really learn with people who were dialed in clinicians. It's a unique environment where under one roof, every domain, every specialty, you're not there for Baltimore, you're there to be the best. And the culture was that, no matter who you called, they were locked in on being a top clinician. And they had world-class scientists, and they respected each other, which was, a refreshing thing. So when I did a research fellowship in the middle of medical school, I took a year off and did something called a Sarnoff Fellowship, which is a 1-year research fellowship for people who are MD scientists wannabes, just to sort of give you a shot at trying to figure out, do you want to do science as a career without investing a full PhD? Yeah. And I went back to Elazar's lab at MIT for that year and really was convinced that, this is a path. And that's really when I figured out that interventional cardiology was for sure what I wanted to do. But I still thought that the whole thing was about coronary intervention, and I was interested in vascular biology and atherosclerosis and treatments thereof. And then I got to the MGH to do my internship and residency, and a guy named Ken Rosenfield got recruited there when I was a junior resident in my second year. And all of a sudden, in a place which was really a historical surgical stronghold, Kenny came in and basically overnight changed the culture of that institution. Now, and he's many things, but, and as sometimes as sort of animated as he is, he literally changed the culture and showed people that, cardiologists could take care of vascular disease and could have a meaningful impact.
So you were there firsthand to
Yeah.
see that transformation.
The hospital, there were many knockdown, drag out fights between him and the leadership of vascular surgery.
Uh-huh.
But ultimately, look, we in cardiology take care of the most athero patients. And as a denominator, there's more of us than there are of any other specialty. And if they just take the time to take off shoes and socks and ask questions, the patients are there. And Kenny was there, Mike Chaff joined, and, the two of them were a dynamic duo of vascular medicine. And it completely changed everybody's perspective of what it meant to be a vascular doc. So, as I was, starting fellowship, I actually left the MGH to go back to the Brigham. I mean, if from the outside looking in, that's probably not a big change. But at the time, those were two culturally distinct entities. And so I left to go back to work with Elazar so I could being at the Brigham made more sense. And, it was clear that intervention is what I wanted to do, but it had opened my eyes to what is vascular disease, what is vascular medicine, and how can interventional cardiology have a role in that? It was all the same questions. But, coronary intervention with drug-eluting technologies had really been invented in part in Elazar's lab in the 90s. And it was still the 2000s and the vascular community hadn't figured that out. And it was only then that things started to really take hold. And it was all the same first principles, but it was much less crowded and much less competitive in a research standpoint. So that was really how the integration of the clinical stuff, which I loved, the procedures, which were much more creative than standard coronary intervention, and the fact that I thought the science was an opportunity that sort of led me to this space. And it was also the dawn of the structural heart era, which is really what's become kind of the vogue in interventional cardiology today. So, my group of co-fellows as a bimodal distribution, either half did vascular, half did structural. But if you were to ask that same question today, it's 95% structural.
Like structural. So before we go into that one path of understanding where people are moving to, because I think that's a very interesting topic, I'd like to learn a little bit more about, and by the way, Kenny is coming on the pod. He's agreed to be here.
Yeah.
So I'll grill him on that a little bit more.
Yeah.
So thanks for that. But I want to, from your, kind of from your spectrum, I mean, from your eyes and you seen that transformation. And I ask it because it seems like still today, despite how much I think we've advanced in intelligent and emotional intelligence, despite how much we try to bring, every so often there's these big steps back where all of a sudden a society goes to war against another society. And, I feel actually very ashamed in how the SVS managed, in the last couple of years and some of the statements that came out. It's just not representing of what I think or what I agree with. But how did that evolve? And do you think there are plays from the Kenny Rosenfield playbook that we can still apply today to try to bring us closer together?
Yeah, well, I mean, I think Kenny will tell you that he's had many a war. Him and Rich Cambria, who's at the time the chief of vascular surgery, had many knockdown dragouts that we all witnessed. We had a joint conference once a week with Rich and Kenny and our respective groups. And actually, my vascular surgical chief at Columbia now, V. Patel, and I were both fellows in the respective groups at the same time. But we wouldn't say anything. We would just sit there quietly and listen unless we were asked to say something. But I learned more from Rich than I think just about any vascular surgeon ever in that 1 year. And he was a generous, educator that way. But the worldview was obviously that these were fiefdoms and turf that was owned, quote unquote, by one person or the other. And obviously we in the coronary space recognize the value of coronary surgery and cardiac surgery. And I have a very close relationship with my cardiac surgeons. And what they did right in structural heart is that they decided up front that we're going to split the revenue. So it was no longer about the money. If you get a TAVR in the United States, there's a surgeon and an IC that are co-scrubbed, and they split the RVUs. And that was by design, so that there wasn't a war. But we have no such memorandum of understanding in vascular. And so it's sort of a, eat what you kill kind of world. And particularly in fee-for-service medicine, that's how people get, put food on the table, so to speak. And so it's created animosity. I think many cardiologists who are not trained in vascular medicine and vascular intervention do things inappropriately because they don't know what they're doing. I think those of us that are trained speak the same language and probably look at things with a similar eye. There's shades of gray, but there's not as much black and white as it is in the field. And so we could all agree that there's some things we agree on, and some things that are, style or cultural. Nevertheless, I think if we're properly trained and we speak the same language and we do what's best for the patients, I think we have a lot more in common than we do different. And unfortunately, it's the money that makes the world go round and makes people angry at each other. It's not, culture or anything else. So I think, in a model where we worked as an institute, if that ever could exist and we put our silos of medicine and surgery and whatever aside, I think we could all coexist and figure out who's the best person to take care of any individual patient. For example, I was just having a conversation with a colleague who is a specialist in venous intervention, who's a vascular surgeon. And, we don't have a person necessarily who's super interested in hybrid endovenous surgical and interventional techniques. And we have a patient that needs that. And I'm going to send her the patient who's willing to drive from New York to North Carolina,
Right.
To get a second opinion. Because we don't have that, but we could have that conversation as colleagues and say, look, I know we can do this, but I don't think the inflow is good enough. It's not going to stay open. Is there a surgical hybrid approach that you think would give this patient a better outcome? But I only know that because I've learned vascular medicine, and I know there's limits to what techniques that we have to offer can give the patient. Those that don't know would probably commit the same mistakes over and over and over again. And then that's why people like you who are surgeons who say, what the hell are these guys doing? They don't know what they're doing. And the truth is they don't know what they're doing. Just because you can push catheters and wires doesn't mean you understand physiology.
Right. Yeah.
So, I mean, I think that the predicate is everybody's got to have the same level of education. And then they have to respect each other's domains of expertise. And that's also a problem. I think there's a undercurrent that, catheter-based therapy is easier than open surgical therapy. Open surgical therapy is a cult of personality. And in my hands, I've never killed anybody, but maybe the national averages are worse than my own personal outcomes. That's a very surgical mindset, I think. Whereas in cardiology, it's become increasingly clear that there are benchmarks and standards that can apply broadly to procedurals. And admittedly, some will be gifted and some will be average, but you have to play to the average sometimes, not to the gifted. And so these cultural things occur in every procedural specialty.
Yeah.
And the sooner we acknowledge and accept it and realize we should get past it, the better off we're all going to be.
So I've heard this, because we had a couple cardiologists here today, and it's interesting because, you operate you live in a silo, and I take it for granted that the whole in my hands, this works, 60% of the time, 100% of the time, or something like that. In cardiology, you don't think you have that?
No, I
that
think
much of a mindset?
I think people know that for certain technical procedures, but there is also quite a good amount of awareness about averages, because the national registry concept really has been embedded. The VQI is self-reported. The difference with the NCDR, which is a National Cardiovascular Diagnostic Registry, which is basically the PCI registry, is that it's abstracted by professional abstractors. And while they work for the institution, they're not beholden to you.
Yeah.
So if your patient had a groin hematoma, you're going to get dinged for it, even if you explain it away.
Yeah.
Right. So whereas the VQI is not always, the data are not always entered that way. If it were, and if it was really objective, which I think they say it is, but I think it's...
Where do you think it's not objective? Because
I think it depends on how your data are abstracted.
Can you go a little bit?
Let me just tell you.
Yeah.
I can
I've been in-
absolutely
I've
tell
heard
you.
of
I just don't have the
I've heard of
expertise.
institutions where the fellows are the ones that put the data.
That's what I was gonna say.
Really?
Listen, how great it is that
I didn't know that.
you should have, fucker.
Why?
Because you were in an institution where the fellows had to do the VQIs.
I didn't do the VQIs.
Clearly.
Yeah. No, but where we are now, we have VQI, but we have nurses.
Abstractors.
Yeah.
Okay. Yeah.
No,
No.
that's right. I think that's
even
the
in
way it has to
Arizona,
go. That's
when
the way
we
it
were
has
in the
to go.
U of A working there, our residents would do it, and it was disastrous.
That sounds like a disaster. Yeah.
Like nobody would put it. Then you'd give them a deadline, and then they'd fill out these things till like midnight, and it's all flawed.
Yeah.
Because it's all these guys up in the middle of the night.
And then all these VQI studies are put up there
exactly,
like they're
the word of God.
That's interesting.
That's exactly the problem, right? I mean, that's why we still need randomized data, because the rigor with which those data are collected is, much, much higher.
Yeah.
Oh, yeah.
Yeah.
And we have lots of registry studies too, but
That's just going to make me more like, how would you say, what's the word? Where you're incredulous
Okay.
of
Big words.
of all
we're
these studies.
circumspect.
Yeah.
I mean, I would say we're circumspect about any of the results that come from that. Now, so take, for example, one of the sort of hot button areas is TCAR.
Mm-hmm.
I think it's a great technique. It's clearly got opportunities to improve outcomes, but there's no head-to-head randomized data for TCAR versus transfemoral CAS. All the data are VQI registry data.
Oh, yeah.
And there are many people who stand on ceremony that this data has the same level of rigor as randomized data.
Yeah.
And I think we all recognize if you acknowledge that the data are imperfect, but the best we have, I think that's a fair statement.
So do you think, because, I've been going on VQI data to kind of suggest TCAR, because I do quite a bit of TCAR, that TCAR is better than transfemoral. When we trained, we did a lot of transfemoral at Baylor, but I completely stopped because I thought these registries were like
I think it
the word
depends
of
on
God.
the patient.
What do you think?
I think it depends on the patient.
If you have an equal, so the lesion, you think it's technically amenable to both. Do you think there's a difference?
I think the DWI hits issue, the hits to the brain is definitely an issue, but that can be done with flow reversal that's done transfemoral.
Yeah.
So I think for the patient to go under GA, which many of them still do for TCAR.
Yeah. What if you
Most
don't?
of them.
So this is okay.
Don't deviate us that much.
No, please. This is interesting.
No, but
I find this very
I think
interesting.
I think that so what has always been the knock against CEA? I think CEA is an elegant, beautiful operation, but the issue is you need general anesthesia, and so the CEA causes more MIs, and and CAS causes more strokes.
Yeah.
And so people were blowing off the importance of those MIs, but those MIs have prognostic significance for those patients.
All right. So because this is a discussion, I'm going to deviate. Okay. I'm going to deviate.
But so if you could do it without GA, a lot of those MIs probably wouldn't happen.
So I do all my TCARs under local, and I get a lot of pushback from my own colleagues as to why do you do it under local? There's no, there's no data to support any benefit, and I just think the data is common sense, right? For me,
I don't disagree with you.
So, but
what is it that you accomplish? What are you trying to accomplish by keeping them awake?
I think, I don't put them in the stress of general anesthesia. I think general anesthesia is another variable. Whenever you include an extra variable into a system,
it's not that you're going to do anything differently.
No,
because you don't give them a violin, and all of a sudden in the middle of the case, you're like, oh shit, I got to go and chase something. Not like,
what violin?
Yeah, like what you're not trying to do a neuro eval during your procedure because you're not going to change anything. You're not in a position to do anything.
No, yeah, I do a full, a full preview. I intervene, and then I do a post view of everything, including the brain, and that's it.
Okay.
But I get pushback saying like, anesthesia is not a big risk, and it doesn't move the needle. So you're doing it under local, great, but it's equal under general, and I don't think it is.
Well, I mean, I think that's the question. Your hypothesis is that there would be fewer MIs if you did it under local versus general. That's a valid hypothesis.
Yeah.
But it's one that needs to be tested rigorously.
Yeah, no, for sure.
And there's no data. Is just saying that in the absence of data, you can do whatever you want. But in order to generate data, it's got to be done rigorously. And that's sort of basically the thesis, is that anything we do has a host of caveats, but the level of evidence and the quality of the data really matters. Take the paclitaxel controversy, right? Everybody says that meta-analysis is the ultimate level of data, but the summary level meta-analysis was clearly flawed. Having participated in the patient level meta-analysis that sort of put the whole question to bed, it was very clear that the summary level analysis was flawed. And people who are retrenched in believing that paclitaxel is killing patients, some of them were influenced by biases about endo being bad and open is superior. Some were biased in the fact that they were betting on a different horse, that a different drug, a different technology, a different approach was better. And some of them were just, I guess, fooled by bad science. But so it was the level of rigor, the quality of the data that led to a misperception that cost patients lives, probably. People who ended up having multiple repeat revascularizations when they didn't have to. I'm sure somebody had a complication and one of those
because it didn't
extra
put
procedures.
drug-coated
Yeah,
balloons.
Yeah.
I don't think drug-coated balloons move the needle that much.
In what sense?
I don't think the overall benefit as far as like for drug-coated balloons is.
It does increase the number of repeat procedures.
It does. Yeah, it does.
And one of those procedures, somebody's going to have a life-threatening complication.
So the principle is if for a couple of years you remove this,
yeah,
and I firsthand was in a group that everybody but me stopped using it. Remember that when that happened?
Yeah, I was there.
Everybody stopped. I said nothing. We keep going. I don't believe the data. I'm not there. We'll add this to the consent. Whatever. Patients were fine with whatever I wanted to tell. And a lot of those patients got more procedures than they should have in the next following years. And so odds are that exposing one same patient to multiple procedures, at some point, somebody's going to have a pseudoaneurysm, somebody's going to have to go under general, somebody's going to have to, somebody's going to need a patch, somebody's going to need an infected patch, somebody's going to go back in for sartorials, somebody ends up with a complicated obturator bypass and dies in the ICU.
Yeah.
This can be.
It can be. No, for sure.
It can be the story of John Doe
for sure
that didn't get the damn balloon and could have had maybe a better outcome.
Yeah.
You never know.
But it was all based on flawed data, which is the part that's so vexing.
Okay. What do you think of best CLI?
I think it's a noble approach, but an imperfect science.
Right.
I think that they did their best, pardon the pun, to answer a question that's difficult to answer. But I was in 2 centers as a vascular investigator. And in both centers, whether a patient had equipoise for endo or open was not my judgment. It was only the judgment of the surgical team.
Really?
And their endo skills were not necessarily, not 100% always as good as our endo skills were necessarily in cardiology. And it was a small fraction of patients that qualified. Of the many patients we treated, maybe 1 in 20 was a candidate.
1 in 20. Yeah.
So I think that
So it's not real
it's
world.
not reflective of our practice overall.
Yeah.
So I think it's an interesting data set. There's a lot that we've learned from it. But the thing that still bothers me is the quality of life data suggested that there was no difference in quality of life outcomes based on the measures that were done. And in a trial where more people got amputated if they got endo than if they got open, if the quality of life was different, my interpretation is that they'd rather get their leg cut off than get a bypass. And so I think we still got to understand the data a little bit better. And I know they're publishing a lot out of that data set. And the investigators, I think, are all, honest guys and gals. I think, on the other hand, there's no perfect study. I mean, Basel and Best have caused as much confusion as they have clarity. And I think we still need to learn more about it. I mean, and the truth remains, I still don't know that, and we have a training gap in our field, maybe getting back to what we were talking about, but I don't know how many of your guys' junior trainees are going to be really good at doing distal bypass in an era where they'd rather just do endo. And we have a similar thing. I don't know how many people in my field are going to choose to have a career in vascular like I do, when they could do TAVRs. There's clearly a movement afoot that training is moving away from some of these old school skills that we sort of harken back to with fondness from when we were training. And I think there is clearly a workforce gap in taking care of these patients the right way. But it all starts with having somebody who knows what the options are and who can have a conversation with a colleague who can do everything. I remember you and I, Miguel, were at some meeting. It was a Viva VLF about CLTI years ago. And the surgeon got up and said, I am the CLTI team, or I am back then we called it CLI. I am the CLI team. That I embody everything that's necessary in taking care of these patients. And I think I laughed. I think I laughed out loud.
We did. We both did.
Because I said, when was the last time you started as a statin on anybody? Right? I mean, I bet you the statin saved more lives than a lot of the things that any of us do. And I think that we have to do it together. The funny thing is, in cardiology, we all know that a diabetic patient with, left main or equivalent probably will live longer if they get coronary bypass with a lima. And there's little ambiguity because the data are so solid, and there's broad agreement about that. And there's a fair bit of self-policing. You have to sort of justify if you're going to do PCI on that patient, because they know that the data are so strong. If we had data like that in vascular, it would probably help everybody, but we don't communicate like that because it's sort of a fiefdom. If the patient comes first to a surgeon that does 100% open, they're getting open. If they come first to an interventional cardiologist that does 100% endo, they're getting endo.
Yeah.
Let me
I
ask
think
another.
my take-home message there, before I try to rein this bull back into,
I'm in it. I'm in the conversation.
I knew I shouldn't have given him a beer this early. No, I think, there is a very valuable message, and I do, I congratulate Matt and everybody in that trial for doing what they did. It was tough. It was hard to get the, finances. Viva actually threw money into that project to push it, past the goal line. But, an important thing, which is, for non-surgeons, is be aware, and this is what I do whenever we go to these like fellows courses that Boston Scientific puts or whatever, because it's, one of each, different specialties, and we're really trying to nurture that conversation and that camaraderie. And so what I'd say is, like, for all of you non-surgeons, just do me one favor, and the one favor is try to know what the diameters of a healthy greater saphenous vein is. And if you don't have a vein mapping, just learn how to do it, because it's very easy, right? So you have an ultrasound for axis. You can open the leg under the drape and just put some gel on the medial aspect of the leg, and you could actually follow the vein down. And if it's compressible and it's got 3.35, it's a patient that can get a bypass. And why do I think that's important? Because when you do that diagnostic and you have all these very complex ways with bidirectional approach and, BVAC catheters for reentry and yada, yada, you may want to check yourself and say, is it easier with that beautiful, juicy vein? Is it better in a stage 3 wound, stage 4 Wi-Fi, that patency may be longer? Or do I really want to fill this guy up with metal? Now, the guy didn't have any GSV, the guy has a bad heart, then go to town, man. Do what you got to do and get that patient open and off the table safely. But have in the back of your mind the notion that a single vein, single segment GSV bypass is probably a really good solution in the hands of a good surgeon. To your point, lesser and lesser that could do some of the distal nifty work, but it's at least a good thing to have, that you don't need to get radiated for 6 hours or throw $40,000 of product to that leg to actually achieve a good outcome that you could get with the stroke of a pen or the click of a text to your friendly vascular surgeon to do a bypass. That for me
I totally agree, Miguel. I couldn't say it better. I mean, I think that's the first they need to know, though. They have to have the knowledge. So, for example, in coronary intervention, we have scoring systems for the complexity of anatomy. Syntax score is one example. So if they have high syntax score, they're better served usually with bypass to get complete revascularization, because it's an easy bypass or a hard PCI or multiple PCIs. We could accomplish the same thing by validating the scoring systems that have been proffered in the global guidelines, for example, or other systems that are easier to remember. And if we did that and took the time and effort to validate those, and we all spoke the same language, the Wi-Fi classification, what's the degree of complexity of the anatomy? Is there a target artery path for this patient? Can we identify an easy one that is going to have reasonable patency? If we know those basic parameters and we agreed on those, we could have much more rich and productive conversations about what's better for the patient. For you guys, that's second nature. That's what you do. For many cardiologists, that's not, and it's our job to get educated. But there's a bunch of us that are not dummies that understand those things.
That know it.
And we should be allowed or get the respect that we're part of the team.
Of course.
And I think a lot of the guys in Kenny's generation, they're still railing against it, rattling the saber, because they have an inherent mistrust of what's going to happen. And some of those things are justified, I think, and I think you'd agree. Some of them probably not. But I think that, if the more we work together, the better we are. The financial incentive piece is difficult to solve. I think in modern healthcare, we all sort of work in some way or shape or form on a productivity model. And until that changes, it's going to be very difficult.
Well, I think the first step, besides learning the size of GSV, is at least twice a year, take your friendliest cardiologist or take your friendliest vascular surgeon and get a beer or go grab dinner and get to know the person, because I have a really good relationship. Do you know Peter Monteleone?
I know him very well.
Yeah, so Peter is one of the cardiologists at Nelson. You work together. He sends me patients all the time. Sometimes he and Manoj was another great cardiologist.
Yeah, he trained with us.
Yeah. So they sent me a patient and I was like, hey man, I would do this endo. I just sent it right back to him. I was like, hey, if you can't do it endo, then I'll try it open, but I would just do it, try it endo. So because we have that relationship, we are friends, we say hi to each other. It's like, hey, what book are you reading or something? So I think besides obviously knowing, most cardiologists are, obviously know what they're doing, but just I think a personal relationship helps.
Yeah, well, I think most cardiologists are good with the technical aspects of the procedures. I think very few have spent the time to get trained in the cognitive aspects. And again, I when I train fellows, it's the same analogy. You know when to send a patient for coronary bypass because you know what are within reason the potential risk limits and alternatives to PCI or bypass. You don't know that for vascular surgical options because you never learned it.
Yeah.
It's not that you can't learn it, you just haven't. And until you do, you really can't call yourself a vascular specialist. So
I'd like to, you kind of brushed on it, and I'd love to circle back to that as we enjoyed talking to you here in the last few minutes because we're getting close to the hour, which you promised us. But you mentioned that it seems that like the workforce on the interventional cardiology side is becoming lesser. Not necessarily that there's not more ICs. I guess you're mentioning that there's less interest in vascular. I mean, you're obviously in a big academic program. You're leading this. What is it that you're sensing, and why potentially do you think this is happening?
Well, I mean, I think that the market forces are partly responsible. That in the last 15 to 20 years, structural heart has really undergone a revolution. Whereas, when we all trained, aortic stenosis was a surgical disease. Today, I would say the overwhelming majority of patients would get TAVR. And that ability to do valvular interventions has really become, it's captured the fancy of cardiologists young and old. And it's become also a big moneymaker for hospitals and health systems, and for the device companies. So, in terms of the numbers of patients afflicted with atherosclerotic vascular disease, that's probably an order of magnitude greater than those with valvular heart disease. But in terms of the market cap, if you will, of the overall business, I think structural heart business is bigger than vascular business. And so it's driven a lot of attention to those areas, and a lot of people have shifted their interest in advanced training to structural heart intervention from vascular intervention.
Is that a national trend, or because
It's a U.S. trend for
Yeah.
sure. Whether it's not global necessarily. Like, for example, in Europe, interventional cardiologists don't do vascular really at all. It's angiologists, and Miguel, you spent some time here. It's even Dirk Scheinert, who's an interventional cardiologist by training, now really spends most of his time doing vascular only. But his cardiology colleagues in Leipzig would never deign to do any vascular. In Japan is the most like the U.S. in that ICs are still doing a fair bit of vascular. But like I don't do any meaningful aortic work. Aortic iliac bifurcation, obstructive disease maybe, but I don't do aneurysms really. We send all that stuff to V. He's great at doing fenestrated and complex aneurysm work. But the best person to do it should be the guy who's the best at it.
Yeah.
So we share a lot of patients, but they do that stuff and we do this stuff, so to speak. And I think that's the thing in the world. The trend seems to be that ICs are less interested than ever in non-cardiac problems. But so, take the innovations in our field recently. Pulmonary embolism is a huge area. It's third leading cause of cardiovascular death after MI and stroke. And pulmonary embolism is a thing that cardiologists have really gotten excited about because the people who get dead are the ones with bad RV physiology, RV failure, core pulmonale. That's a cardiac kind of diagnosis that, people can get their hands into. They're not interested as much in CLTI, which is the most mortal disease that many of us take care of outside of cardiogenic shock as interventional cardiologists. But we just can't seem to get people interested. They're a lot more interested in, doing a peripheral case and then deploying a valve at the end.
So do you think that that's going to become a bigger like societal crisis? And let me maybe reword this in the sense that my biggest beef with my own society is this self-proclaimed notion that somehow we are the best and that we should be probably the only ones who are out there taking care of patients with CLI. Well, my biggest beef is that
they don't say just CLI; they say all vascular patients.
Vascular disease. Yeah. Well, here's the deal: you can put all of us, and we don't fill a stadium up. All of us.
Yeah.
I don't think there's enough to fill the Dallas Cowboys stadium. Okay, which means that we have no capacity to take care of the problem. Okay, so even if we did get everybody, then we would just bog down and not be able to do anything. But now you're telling me that there's less and less ICs, and I'm not saying that every one of them is amazing at doing vascular work, but there's probably a significant amount of them that do really good work, or that could eventually train into doing really good work, but they're not going to be there. So it seems like it's a snowball problem that nobody's going to be in a position. There's not going to be enough of us, period, on either sides of the aisle to actually step up and do what the people the people in America need us to do.
No, 100%. I think that's absolutely true. And it's even worse in the developing world. So I'm Indian by background. I was born and raised in the U.S., but my uncle died of fetal sepsis, my dad's brother, and it was because I got an angiogram sent to me, and it was too late by the time I found out about it. And he died in a big city, Mumbai, where there's capable doctors to take care of it. But he was told that nothing could be done for his CLI, and nobody's willing to do a bypass or an endo procedure. And he died from it because they didn't have the workforce to take care of it. And the truth is, he had easily remediable disease. And that's what breaks my heart.
But you don't have to go as far as Mumbai. That happens all the time
It happens
in South Texas.
It happens in Washington Heights, where I practice now. But what I'm saying is that there are going to be fewer and fewer people interested, I think. My IR colleagues, more and more of them are interested in interventional oncology and other things that are like the structural heart of interventional cardiology that are attracting more and more of them to more lucrative and prestigious careers.
Is there? That's what's going to be my question. Is it more lucrative?
It seems so. I mean,
I can
I'm of the
understand
cynical
that
opinion.
Yeah, I can understand.
I can understand that being a significant thing that sways you. I mean,
I'm of the cynical opinion that money drives everything. And, if you follow the money, usually you figure out the answer. And I do believe that that's sort of part of the challenge here, even though our ability to affect the public health of America and the world is so intense. It's probably as much as anything else.
So what do you think about the potential solution? Have you thought about things that we could do in order to bring some people back to the table?
Well, I think we need to lower the barriers, because a lot of people in interventional cardiology, I know, perceive it as it's going to be a fight. Because our society, the ACC, really has soft-sold our role in the care of the vascular patient. They would rather get pre-op nuclear stress tests from vascular surgeons doing open surgery than they would have us doing vascular medicine and intervention. That's my sort of overall perception. It won't be popular amongst the college, even though I'm a card-carrying ACC member, but that's my belief. And that's how many things have happened. And for example, the NCDR, which is our National Cardiovascular Data Registry, they have sort of gotten rid of the PVI registry, the Peripheral Vascular Intervention Registry, out of it and given it to the VQI so that there's no other public registry other than the VQI. They weren't making enough money off that product, so they just gave it away. And never really listening to those of us that are vascular interventionists were card-carrying members of the ACC. And the people who made the decision in the NCDR were all structural heart interventionists who've put those monies towards various structural heart registries and other things from which they are obviously making money and are more interested in. So I think if we set all that aside, if we as a vascular community got together and tried to show people how cool of a job we actually have and how much of a public impact we have, and importantly, how gainfully employable we are because there's such demand, I think we can turn the tides. Because I think, the future is changing. The folks going into medicine today are of a different ilk than we were. They're not first generation immigrants like the three of us necessarily. They're more lifestyle oriented. You can have a great lifestyle and still do a great job and take care of patients with vascular disease. We just got to do it together.
Yeah.
Right. Wouldn't it be great if we all worked together in a single group that was a multi-specialty group where I help you guys with all the medical management and some of the coronary work, which they all have, and the endo stuff that sometimes you're not able to do, and vice versa.
Or we do cases together.
Even more fun.
Even more fun. Yeah.
I mean, you guys know I took a leap of faith in leaving the hospital systems and opening something that I think could be a center of excellence. But I think if we're able to perfect this model and we're able to show, margins that align financially and lifestyle with people, I would be the first one to hand the blueprints of this to any interventional cardiologist that says, you know what, I'm interested in going out to places where there's nobody there. What are you doing that works? And, what do I need to, but to your point, I'd be happy, but I'm like, okay, well, you're going to learn about wound care and you're going to work with your podiatry group and you're going to learn about
competencies.
And if you learn this, there's no reason why you can't, and still know that there's going to be maybe a subset of those patients that you're probably going to send for bypasses. But you can be, you can be the administrator of that site of service. And so maybe there's also a solution here of empowering physicians through the also rise of ambulatory surgery cardiovascular centers. Because maybe that could be something. Because you're never going to go and do a TAVR in an ASC.
No, but
I don't think
PCI is moving in that direction.
PCI is. And
coronary diagnostic catheterization.
So what if you could be part of it?
And never say never.
Oh yeah, never say never. But what if you could be part of an ASC group that maybe is multidisciplinary? You do your coronaries and you do your peripherals. Yeah, you may not have the shiny TAVRs, but you still have privileges at the hospital if you want to drive in and do those cases. But this may align better with lifestyle if you care to be with your family early. You're not fighting the convoluted schedule of the hospital where everybody's getting bumped for different things. You're not fighting hospital administration or HR or all these other things that make our lives difficult at times. So maybe there is also something there in some of these novel sites of service that we should try to explore. Because at the end of the day, if you do get some societal support, what I think you need to do is a big, strong PR campaign. Because you're going to have to go out there and, and put like live cases and show and create models and training courses and show that you can make, X amount of money or I don't know what it is. If you're looking for X amount of figures that you can do, and these are the blueprints on how to get there, that is how you're going to get the buy-in. It's going to be like, there has to be an investment. So Ben, the question is, who's going to invest in the project? If the leadership of ACC isn't necessarily there, it almost sounds like potentially it has to be some sort of industry also alignment, because if there's no ICs, then the industry business also is going to start tanking because people aren't doing the cases.
Yeah, well, I mean, I think that it's going to take a village, but I think that the societies, for example, SCAI is representing us as interventional cardiologists, and I think SCAI is much more interested and willing and able to support this. OEIS is another group that we all know about, and then there's maybe some of the other baby societies that are the sort of subordinate to the big mothership of societies. For us, it's ACC. For you guys, it's SPS.
Yeah.
And there's other clinical societies that may be appropriate. But I mean, I think at the end of the day, it's still going to take individuals to kind of come together and say, look, this is a model that we can execute on and that works. And we're going to move that forward.
Well, here's a peace offering in a way. Again, not that a whole lot of people other than our family members listen to this, but as this potentially becomes an additional way to get messages out, whenever you have something that you feel the world should know, I want you to know that the lights are on in the Life of Flow house, that this is your home, that we view you with love and respect, and that anything at any point in time that you want to share with us, just give me a ring and we'll have you on the show, man. Because it's been nothing short of just amazing.
Yeah.
You are a book of knowledge, and it's just so easy and fun to talk to you and very inspirational.
Appreciate you guys. And likewise. So, I think that we're stronger together. That's for sure.
For sure.
And it's a hell of a lot more fun.
It's way more fun.
Thank you very much.
Appreciate it.
Thank you.
Bye-bye.
Thanks, guys.